Welcome, everyone. Thank you so much for attending today's installment of Hot Topics in Public Health, where we're going to focus on 30 years of tobacco control research and intervention, looking forward, looking back. Before we start the program, we want to recognize that our university sits on lands of the Ho-Chunk Nation. We also recognize the health disparities faced by our Native communities and publicly affirm our commitment to help address those disparities. As the nation's first school of medicine and public health, we are committed to bringing together the power of each of these disciplines in addressing major challenges to the health of the people of Wisconsin and beyond. In all our missions, we seek to create synergies that will benefit people and populations with special attention to health disparities. Today's topic focuses on an incredibly important medical and public health challenge: tobacco use and tobacco addiction. The use of tobacco products continues to be the leading upstream cause of preventable death and disability in the United States. The numbers are staggering and, quite frankly, depressing. 1 in 5 deaths is a result of smoking. 9 out of 10 lung cancer deaths are due to smoking. 8 of 10 chronic obstructive pulmonary disease deaths are due to smoking. And smokers have a 4-fold increase in heart disease and stroke risk. While we have made wonderful progress in so many ways over the past several decades, deadly challenges remain in our efforts to eliminate the morbidity and mortality caused by tobacco. Thus, the wise selection of smoking cessation for our hot topic in public health. We are so blessed to have Mike Fiore, Dr. Fiore, here today for this conversation. Mike is truly one of the world's leading experts in this area, and his incredible impact is, quite frankly, unsurpassed. As the founding director of our UW Center for Tobacco Research and Intervention, he has advanced the cause of tobacco cessation here in Wisconsin and really throughout the entire global village. He has served as a mentor for a whole generation of scientists, created evidence-based practices and programs, and contributed to some of the most impactful publications in the field. Tonight, we will benefit from Mike's experience and wisdom while celebrating his remarkable career spanning the last 30 years since the creation of the Center for Tobacco Research and Intervention in 1992. In reflecting on just one story in the epic tale of Dr. Fiore's career, I came across a wonderful personal anecdote that he once shared. As a child growing up in Boston, he remembers the doctor who smoked while examining Mike and his siblings, dropping ashes on them while he worked in the exam room. So we've come a long way, and much of that journey has been propelled by Mike's total commitment, innovative spirit, and wisdom. Dr. Fiore truly embodies our school's vision of healthy people and healthy communities. I want to finish with some thank yous, some heartfelt thank yous. The most heartfelt to our remarkable speaker, Dr. Fiore, and for all that he's done over the years. And also to tonight's moderator, Dr. Pat Remington, Professor Emeritus of Population Health Sciences. Special thanks to Dr. John Tempte, our Associate Dean for Public Health and Community Engagement, who leads this event series. And of course, a wonderful thanks to Tracy Gatos and her remarkable team who behind the scenes pull off this event. So now, consistent with this event's title, I'm looking forward to the program as we look back on a generation of progress and Dr. Fiore's personal involvement and highly impactful leadership. So I'll now turn over this virtual podium to John Tempte. Thank you for joining us.
And thank you so much, Dean Golden, and greetings to everybody this evening. One of my very first memories is that of green and white packs of cigarettes in the kitchen cupboard, much higher than I could reach. This was the legacy of the weekly cigarette ration my dad received during World War II, which started his tobacco journey. Shortly thereafter, faced with chronic morning cough and a recent Surgeon General's report on the dangers of smoking, he quit. Growing out of the Great Depression and fueled by World War II, annual tobacco consumption in the United States reached an average of 12 cigarettes per adult per day in the early 1960s. Then a wonderful alignment of medicine and public health occurred. In 1961, the American Cancer Society, the American Heart Association, the National Tuberculosis Association, which was the predecessor of the American Lung Association, and the American Public Health Association petitioned President Kennedy calling for a national commission on smoking. Meeting from November 1962 through January 1964, the commission reviewed more than 7,000 scientific articles and involved the help of 150 consultants. Surgeon General Luther Terry issued the commission's report in January 1964. Recalling the event, Dr. Terry reported that when this hit the papers, it was like a bombshell going off. This had tremendous effects across the country and beyond. Next slide. So over the next 30 years, cigarette consumption slowly declined. Events starting in 1992, which was the founding year of the UW Center for Tobacco Research and Intervention, founded by Dr. Michael Fiore and Dr. Tim Baker, are the topics of tonight's symposium. I have the great pleasure of introducing Dr. Michael Fiore, the director of the Center for Tobacco Research and Intervention and the Hilldale Professor of Medicine. He received his medical degree from Northwestern University, his master's of public health from Harvard, and his master's of business administration from UW-Madison. His accolades are far too many to list, but I will note that he's a member of the National Academy of Medicine and the senior consultant for tobacco cessation policy at the National Cancer Institute. Dr. Fiore has more than 250 peer-reviewed articles. His latest actually appearing in our own Wisconsin Medical Journal. He has been the principal investigator of many NIH grants. Moreover, he cares passionately about the health of individuals and populations and embraces the role of prevention. The reach of CTRI has been immense. For example, this continuing education course has the highest enrollment of all enduring courses through the Interprofessional Continuing Education Partnership. It has reached all but 2 states and as far away as Brazil, Egypt, and Australia. If you wish, use the QR code to obtain more information on this offering. One other offering from CTRI relevant to tonight's discussion is this review of treatments for tobacco use and dependence. If one searches PubMed, crossing Dr. Pat Remington with smoking, more than 70 citations emerge. Serving as our moderator tonight, Dr. Remington is Professor Emeritus in the Department of Population Health Sciences, the Associate Director of the UW-Madison Preventive Medicine Residency, and the former Associate Dean for Public Health. He was instrumental, along with Dean Golden, in creating the first combined school of medicine and public health. Finally, I would be remiss if I did not end my comments with an appropriate symbol. I turn our discussion over to Doctors Fiore and Remington with my thanks.
Well, thank you, John. And it is truly an honor and a pleasure for me to have this conversation with Dr. Fiore. We've known each other for more than 40 years and have worked very closely together throughout our respective careers, mostly here in Wisconsin. And Mike, I have a series of questions that have been developed by various faculty, staff, and even students submitted some. We've also gotten some submitted from the audience in registering for this conference. And I understand throughout, if individuals want to ask a question, they can do so in the comments. But I wanted to begin with when we shared these questions with you in preparation, you got back to me and said, these are great questions, but the predominance of questions about vaping and e-cigarettes sometimes dominates what is the most important message that you want to convey. And can you sort of reflect on that? What is sort of your general message about the burden of tobacco control today?
Sure, Pat. And thank you, Dr. Golden and Dr. Tempe, for your really kind introductory remarks. I'm happy to have this discussion tonight. You know, when we go back to, as Dr. Tempe said, of 1964, when the Surgeon General's first report was released, about 42% of all adults smoked. It was a remarkably different environment that, for those of us who weren't around then, can't even imagine how ubiquitous cigarettes were in our society. They were part of everything. And back then, everybody smoked. If you were rich, you were poor, you were educated, you were uneducated. As Dr. Golden mentioned, doctors' offices had ashtrays. When you went to a lecture in college, the professor was often smoking in the front of the room. The students were as well. And the CDC has said that the progress we've achieved around tobacco use in terms of cigarette smoking is one of the 10 most important public health achievements of the last century. So back then, 42% of adults smoked. Today, about 12% of adults smoke. It's really remarkable. But two things about that. One, smoking has become a disparity. It's the poor, it's the least educated, it's those with mental health and substance abuse diagnoses, and it's Native Americans who smoke at the highest rates. That's the first point to say. But also, even at 12%, we've got 30 million Americans who smoke. And half of them, 15 million, are going to die prematurely because they burn cigarettes and the 7,000 plus constituents get into the pulmonary bed and lead to cancer, cardiovascular, and pulmonary outcomes that are adverse. So I always urge people to keep our eye on where the damage is. The damage comes primarily from burning tobacco, combusting tobacco. Thus, if we truly want to reduce the 500,000 deaths that occur in America every year from smoking, we have to eliminate the burning of combustion. I know we'll talk more about e-cigarettes. I'm not giving them a pass, but let's not forget that most everyone who dies from cigarettes, dies from tobacco, dies from smoking them, not from using them in any other way.
Great, Mike. Thank you for that sort of beginning comment on the landscape of the real importance of looking at where the 500,000 deaths that we see each year in this country alone come from. We're going to get back to the question of special populations, but one question I did want to ask is, how did you get into this area from medical school to your training in epidemiology to your decision to do your preventive medicine residency at the Office on Smoking and Health? When did you sort of jump into the tobacco field as a professional endeavor? And was that an overnight decision, or did it evolve slowly from your early work in this field?
It wasn't overnight. I mean, I could even think back to my applications to undergraduate school when I emphasized that I wanted to be a doctor who focused on prevention. So I've always been committed to public health and prevention, although I'm trained as a clinician, board certified internist. Um, I had the privilege of working for the CDC as you have had, Pat. And after 2 years as an epidemic intelligence service officer, I was invited to be a preventive medicine resident and chose to go to the United States Office on Smoking and Health, which at that time was in Washington, D.C., part of the CDC. And the Surgeon General at that time was C. Everett Koop, and he was a dynamic leader who passionately was against tobacco. I got to work side by side with him for over a year. And at the end of that year, I was passionate about devoting my career to tobacco dependence and helping people who are addicted to quit.
Can I just follow up on that?
Sure.
You maintained a long friendship with C. Everett Koop. Can you talk about his influence on your career, the importance of mentors in all of our careers, but particularly maybe hear a bit about C. Everett Koop as an individual, as a pediatric surgeon, but a Surgeon General also?
Yeah, well, C. Everett Koop was a remarkable guy, and he's passed away a few years ago now. He lived to just shy of 100 years old. Um, he was an incredible mentor to me, and he was a firm guy. He'd let you know if you did well or if you didn't. And he would not sugarcoat everything and say you're just the greatest thing walking. He had incredibly high standards and demanded that those around him had them as well. For those of you who weren't around during the period of time that he was the Surgeon General, it was the 80s, actually, the early 80s. He did two things that were phenomenal. One of them had nothing to do with smoking, but it was about HIV. And he was the first person to personalize HIV and to say that this is a public health catastrophe that we have to address. And it was remarkable because he always was a devout Christian. And people said, as a Christian, you shouldn't be um, helping individuals who are primarily gay. But he did anyways because he said, I'm the Surgeon General and I have to focus on the health risks here. And that's what I'm going to do. So he did that. The second thing he did was to focus on smoking. And he released a Surgeon General report for the first time, said that cigarettes are addictive. And that changed it from smoking being a lifestyle choice to smoking being a chronic disease of addiction. He released another Surgeon General's report that had equal impact, and that was that secondhand smoke is harmful to the people who are exposed to it. So it was no longer that I'm an individual, I'm going to choose to smoke, but rather, if I'm smoking in front of you, Pat, your health is at risk, and I don't have the right to do that. And these two reports on addiction and secondhand smoke totally changed the landscape, and for the first time, and from my perspective, put the tobacco industry on the defensive and said to them, you're producing a product that's not only killing people, but is addicting them and is causing innocent bystanders to also be harmed.
Yeah, that was a great point. And when those reports came out, he was the most prolific Surgeon General in the publication of those annual reports. And I know you contributed to a number of them. Let me shift the conversation to the questions that we've gotten. We got two questions about menthol in cigarettes. And some people may not realize that menthol is in cigarettes, that those are sometimes targeted to certain populations, youth, LGBTQ, communities of color. So can you give us a little bit of the rationale or the history of menthol cigarettes, and then talk about what's happening as we speak at the FDA? And then maybe finally, why has it taken so long for us to address this issue?
Yeah, and if I miss any of it, Pat, you just
I
give me a
will.
prompt afterwards. So,
Sure.
menthols so menthol is an additive to tobacco. And it's important to remember that cigarettes, which contain tobacco leaves, contain a bunch of additives, many of which are poisonous and almost all of which are harmful. Menthol is a flavorant, and it started getting added, I believe, back as far as the 50s to cigarettes, the 1950s. And the tobacco industry documents that are available have said there's a couple reasons for that. The tobacco industry always wanted to expand the marketplace. And some people, particularly when first starting to smoke, had difficulty tolerating cigarette smoke. Menthol, which is a local anesthetic as well as a flavorant, allowed people to inhale when they would have had trouble inhaling without the menthol flavoring. This has real importance because it is the gateway cigarette to many youth. Most youth start smoking menthols. And if we examine this type of cigarettes that adults smoke, younger people smoke menthols at a much higher percent than older adults. There's another difference, and that is that African Americans, for the most part, smoke menthol. The surveys say between 80 and 90% of African Americans who smoke menthol. And this is, if you go into an inner city neighborhood or an African American neighborhood of any city in America, every convenience store is plastered with African Americans smoking menthol cigarettes. Cool and Newport are the two most commonly and the most popular brands. So it's a disparity from the perspective of targeting African Americans. And the targeting is not just through advertising. The tobacco industry has for decades given funds to African American nonprofit groups, churches, etc., as a way to entice them to be in the fold of the tobacco industry. Unfortunately, it's a way that the tobacco industry has always enticed people. It's a sad way because many individuals are on the payroll of the tobacco industry. So you mentioned the FDA. Here's the good news. Back in 2009, the Tobacco Control Act was passed as part of the one of the first laws passed by Obama in his first term. And it had a lot of provisions, many of which are continuing to come forward now. But one was it gave the FDA the right to remove menthol from cigarettes. And that was 2009. So here we are 14 years later. It has still not happened. And it hasn't happened for political reasons, unfortunately. The tobacco industry fighting it, along with, frankly, a lack of will in Washington by our politicians to enact the provision that was part of the Tobacco Control Act of 2009, which asked that it be done within a year. And of course, it was not. Here's the one bit of good news in this sad story. It appears that it will be enacted by the end of this year. The FDA will ban menthol from all tobacco products. Unfortunately, the same day that it happens, the tobacco industry will sue the FDA and it'll be tied up in court.
Hmm.
And to the issue of why it's taken so long, I would say it's a few reasons, but the biggest one is a lack of political will. There's any efforts to control the tobacco industry, because they're so wealthy and they spend a ton of money on political contributions. People are reluctant to call them for what they are, and that is the biggest killers in America.
Well, this segues perfectly into the next question. And that has to do with this changing framework. I actually teach an undergraduate course, Introduction to Public Health, and one of the recent lectures was on the commercial determinants of health, the idea that we have environmental, behavioral determinants, social and economic determinants, but this idea that there are political, commercial determinants of health. And what are your thoughts about this sort of recognizing the role of the industry, particularly, and politics, whether by inaction or otherwise, in public health? The thought of that framework to sort of put the industry as a determinant.
Yeah, I mean it is without a question a determinant. So I agree with that framing. Tobacco, more than most issues, is a highly politicized public health issue. Kind of imagine the scenario that, Pat, you discovered a new product and you started selling it, and it killed half of the people that used it. That's what cigarettes are. It kills half of the people who use it if they don't quit. And most of them don't quit, unfortunately. No other product in America damages the public the way tobacco does. And unfortunately, as a society, we have condoned it for decades. We've made clear progress in getting it down to a prevalence rate of about 12% today, 12% of adults today. But who continues to smoke? It's those with the least power, the least influence in our society, the poor, the least educated, those with mental health and substance abuse diagnoses, Native Americans and Alaskan Natives. It's people who really are struggling and don't have a voice or particularly any power to change things. I'll
Well,
stop there.
it's a great point, and we could go on about the industry. In fact, I'm looking at the next question. The knowledge of the tobacco industry playbook that evolved during our respective careers, the shift in the focus of many public health campaigns to really focus on big tobacco. What's been your experience on this shift from basically the Great American Smokeout approach, which is, pick a day in November and just quit, to recognizing the role of the tobacco? Are there opportunities for other areas in public health to understand the role of industry and or moving forward to make continued progress? What about the role of industry? What can be effective moving forward?
Yeah, I mean, the industry is a remarkably I don't want to get overly dramatic here, but a remarkably evil enterprise. It's an industry that makes its profits by selling a product that again kills half of the people that use it. It's unequal. Back in the around 2000, I was asked by the United States Justice Department to serve as an expert witness against the tobacco industry in their landmark lawsuit that accused the tobacco industry of racketeering, the same laws that go against the mafia and other groups like that. And to the Justice Department came and asked me to do this, and I felt I had to do it, of course. And I spent 6 months of my life prepping for the trial, being deposed by sometimes in rooms with 20 or 30 tobacco industry lawyers. I was on the stand for 3 days, and the tobacco industry attempted to make it very personal. Nevertheless, the one good thing about not just my experience, but everybody's experience is there aren't a lot of people that like the tobacco industry. So they have little credibility, although they continue to misinform. For example, the tobacco industry frequently says now they're no longer in the tobacco business, they're in the harm reduction business. And they're pushing e-cigarettes because these are less dangerous than combustible cigarettes. And they're right, they are less dangerous than combustible cigarettes, but that doesn't mean they're safe. And with the former Assistant Secretary of Health, Dr. Howard Koh, I recently wrote an editorial where we said, if to the tobacco industry, if you're interested in harm reduction, stop selling cigarettes today. You could do that, and you'll take the big harm out of the mix and sell all the e-cigarettes you want, but stop selling combustible cigarettes. They've chosen not to take us up on that recommendation.
I can imagine. They probably didn't think too long or hard about that response. One of the questions I'd like to circle back to is your focus on helping addicted smokers quit, following the Surgeon General's report. And obviously, I think the general public understood the addictive potential of cigarettes, but once recognized, you really developed a national center of excellence, focusing on helping better understand addiction, but then changing systems so that tobacco cessation became the fourth vital sign. And can you talk a little bit about that idea that you came up with, and how that began sort of your career, basically not only understanding better the science of cessation, but then getting people to do it?
Yeah, well, I'm a clinician. My heart is in clinical medicine. And for that reason, I focused on cessation. It was something I wanted to do. And if we look back to when I got started in this, there really weren't any options. There was nicotine gum, but not much of anything else. But what we did know was that smokers were going in and out of clinics without tobacco ever being even recognized. And I saw this as an incredible lost opportunity. We know that about 70% of smokers visit a clinician every year. And to me, that seemed like, why don't we go where the smokers are? And that's in the clinics. And the first thing we need to do is to identify them. And if there ever was something that was vital, it is whether a person smokes or not in terms of their immediate health risks as well as their long-term health risks. So it was a different time, but I just wrote to the editor of the Journal of the American Medical Association and I said, I would like to advocate for expanding the vital signs to include not just blood pressure, pulse, temperature, but also in respiratory rate, but also smoking status. And it was a very forward-thinking editor, and he said, "Write it up and let me see it." And that's how smoking status as the new vital sign happened.
Who was that? Was that Drummond Rennie?
No, if I
George. George.
yeah,
Okay.
Lindbergh, I think, or
George
something.
Lindbergh. Yeah. George Lindbergh.
Thank
Yeah.
you.
Very forward-thinking editor, but a great idea. Good idea for junior faculty or students, that if you have a good idea, it's always nice to sort of test the water. And sometimes you'll find editors who are willing to help in that journey. Let's talk, though, about getting your work to change systems. One of the things we teach in public health is we need to move from simply helping individual smokers quit, extremely important as a clinician. But what about your work to actually change the system? The idea that for the fourth vital sign was brilliant, but if the system doesn't change, then we're going to be doing the same things over and over again. So what work have you done to change the structures, the policies, the financial incentives, the whole system to do a better job of delivering these services?
Yeah. And I just want to stop by saying I am incredibly fortunate in having founded and work at a center that has currently 50 staff members who are incredibly committed to tobacco control, and much of the work that is associated with me comes from them. And I just want to give a shout out to everybody at the Center for Tobacco Research and Intervention who have worked over the last 30 years to advance our mission of eliminating tobacco use from our society. So, as you said, there's many ways to change systems, and we've worked in most of them. We were asked, and I was personally asked, to chair the federal panels that wrote the first ever guidelines, public health service clinical practice guidelines on treating tobacco use and dependence. That had enormous impact because for the first time it said, this is what the evidence says helps if you have a patient that smokes. It also designated tobacco use as a chronic disease. So it took it out of this realm of a bad habit, but rather this is like any other chronic disease that I, as a physician, should address. I wrote an editorial called Tobacco Cessation and the Good Doctor Club. And that is, how could you be a doctor and not address tobacco use with every one of your patients that comes forward? We did a lot of work with the Center for Medicare and Medicaid in Washington about reimbursement. We worked on the Affordable Care Act to ensure that tobacco cessation was listed as one of the treatments. We've worked with the Wisconsin the Wisconsin Health Department to ensure that Medicaid covers smoking cessation treatments. So there are scores of ways that we can do this, and we've helped, and you've been involved in that yourself, Pat, in a really meaningful way over the years.
Yeah, I think that has been a legacy to really look at the systems of care and value what we will pay for what we value, and we tend to value what we pay for. One of your JAMA viewpoints, one of the questions that came in, you and your co-authors called out hospitals on the U.S. News and World Report honor roll for electing not to report tobacco treatment performance as part of their joint commission reviews. And that pointed out that our own University of Wisconsin hospital is on that dubious honor roll list. Anything change as a result of that publication, and how can we do a better job right here in our own backyard with this policy, this approach?
Yes, well, I had the privilege of working with the Joint Commission to establish a tobacco cessation performance measure, which basically everyone knows when the commission asks for something, people will do it. No hospital can tolerate not being approved by the Joint Commission, but the performance measures are optional. And there's a list of about 15 of which they report on 4. And what we found is that the best hospitals in America almost universally do not report on tobacco use, including the University of Wisconsin. Um, it was embarrassing, but I can't say that there was a marked shift. It only came out a year ago, so we'll see about a year from now if that proportion is increased. But U.S. News and World Report has not changed the way they were markups hospitals in terms of this variable.
Okay, so some work to do right here at home.
Yes, without a question, without a question.
Another question asks, we've made a lot of progress in health systems and healthcare teams to reduce nicotine use, nicotine dependence, or even preventing kids from starting to smoke. But on your wish list of what would you like to see happen if you were a health system CEO to change tomorrow? What could we do better in health systems or healthcare teams? Either maybe let's talk about cessation, and then I want to pivot to issues of prevention.
Sure. Dr. Koop said that we need to make it as easy to get help quitting as it is to go down to the corner store and buy a pack of cigarettes. It's darn hard to get cessation treatment. Even at our own institution, we don't have readily available trained cessation treatment broadly available for every smoker who comes through the door. So I would say efforts that focus around removing barriers to access to treatment and then making it readily available would be 2. But on the policy side, which was the second issue you mentioned, remarkably, the Tobacco Control Act of 2009 provides a solution to the tobacco problem. Again, 14 years later, we haven't yet taken advantage of this solution. And this is the song that I sing most when I talk about what we should do now. One provision of that law said that the FDA could force tobacco companies to reduce the nicotine content of cigarettes to near zero. It can't be zero, but it could be non-addictive levels of nicotine. We've done not us here in Wisconsin, but the collective research community has found that if we reduce nicotine to near zero, non-addictive levels, the smoking rate within 3 years would fall to about 2%. So we have a solution to the problem, and it would be a sea change in America. And unfortunately, there has not yet been the political will, but I think it may, the draft rule may be released in 2024. We'll see.
Well, that's interesting. So the idea of in combustible cigarettes of being able to ratchet down the nicotine level to a point where it's no longer a nicotine delivery device that again kills up to half its users. What about the fact that now nicotine use is increasing, particularly in youth, through e-cigarettes and vaping? Is that, I'll just ask the question that I get asked often, is this a good thing for public health or a bad thing for public health? The wide availability of nicotine that comes without having to be in a combustible cigarette.
Yeah, you broke up a little bit, Pat, but I think I got the gist of it. Um, so e-cigarettes, it's a giant topic, and it's complicated by the fact that the e-cigarette companies and now the tobacco industry, which owns virtually all of the e-cigarette industry, has used it as a way to recruit young people. And that's where the problem lies, that e-cigarettes were made very appealing to young people and marketed to young people in really devious ways. And very quickly, it became the drug, the nicotine delivery product of choice for young people. So by around 2017, 2018, when e-cigarette use was at its peak, 40% of high school seniors were using e-cigarettes. It was a shocking statistic. We're now down to under 15%. And it's in part because of some control measures that have been put in place. So e-cigarettes are a giant problem because they've been marketed for young people. They're a particularly complicated issue because they also may be a product that people who aren't able to quit combustibles in any other way are able to switch into that as a means of getting their nicotine and in that way get off of deadly combustibles. But the problem is what's happened with young people. The good news is we've made progress in reducing youth access to and thus youth use rates of e-cigarettes.
Well, that's a great point. So, how do you have the benefits of, because is it not true that e-cigarettes are a common use of smoking for smokers who want to quit? It has increasingly become the drug of choice or the approach of choice. And how have you seen that change from nicotine gum to patches to, other medicines, and now the wide accessibility of vaping products? How has that changed the milieu of nicotine replacement therapy for cessation?
Yeah. Well, first go back to what cigarettes do. So I take a drag of cigarette smoke. It nick the particles of smoke are covered in nicotine, and they're the perfect size to enter the lungs all the way down to the alveoli. So I take that drag of smoke, this perfectly sized molecule gets into my alveoli, and within 10 seconds, my brain is bathed in nicotine, and norepinephrine and catecholamines are released. I have a sense of pleasure, of relaxation, of calmness. It's a wonderful drug delivery system, and that's why it's been so successful as a product. E-cigarettes kind of do the same thing, not as well, but the same thing. I take a drag of vape, and I get it into my lungs, and I could deliver it into the um, uh, into the pulmonary venous bed, which means it goes to the left heart, and it's to my 10 seconds. So that product is, that's an incredibly effective way to deliver it. And because it has fewer other chemicals in it, it's probably safer than e-cigarettes. But here's the risk. It's only been around for a decade. We really don't know what the long-term effects are. And what the goal should be is a world free of nicotine and all the products that deliver it. There's no inherent need in our bodies for nicotine. And there's a lot of dangers to it. We had a pulmonologist visiting a couple days ago, and he said something that I thought was really powerful. And he says, as a pulmonologist, I don't want anything going through the alveoli. Why would we put stuff into our alveoli? So I would say, while it is better than combustibles without a question, it's not the solution to combustible tobacco addiction.
That's a good point. And there are other ways to help smokers quit that don't come with that complication.
Right. And the challenge is that none of them give you a boost to your brain within 10 seconds.
Like vaping. Yeah.
Yeah. Or
So-
cigarettes.
So we have a question from the audience, and it pivots really back to your main point early on, that combustible cigarettes continue to kill 500,000 people in this country every year, but particularly that disproportionate burden on special populations. So if indigenous people, Native Americans in particular, are disproportionately impacted by the effects of smoking, what about the American Spirit brand, and thoughts about this as specifically targeting this issue of sacred tobacco use in tribal populations?
Yeah, so you got to remember, as I said earlier, that the tobacco industry is all about expanding its reach and expanding it to different subgroups of patients and individuals, I should say, to use their product. And there are some people who are very interested in organic tobacco and tobacco without additives. All well and good, but the reality is that tobacco by itself, if you burn it, kills you. You don't need additives. You don't need pesticides to kill you. So there's a group of people that the tobacco industry, through their incredibly effective marketing, has said American Spirit cigarettes are organic. They don't have any additives. They don't say they're safe, but that's the implication. And a lot of people think, well, it has no additives. And I say again, you don't need additives to tobacco. If you burn them, it kills you.
let me build off of that. The tobacco industry since the 1950s has been in the business of misinformation, disinformation. But that's come up more recently in contemporary public health issues like the COVID pandemic or climate change. What's your advice in attempting to combat this intentional use of misinformation, disinformation, for other people working on other public health challenges like confronting COVID or climate change?
Yeah, well, it's a giant problem, and it's even greater in this era of social media because so many subpopulations can be communicating among themselves. You got to call them out for what they're doing. Call them out pure and in as simple terms. Make it relatable to the average person. Don't get caught up in our medical jargon and in our sort of the almost the uppityness of us as we know we're the doctors. We know that's right. People don't want to hear that. They want to have something that's relatable to them. The arrogance of some of our public health messages, I think, has led to missing our targets.
It's a good point. It is all about credibility and connection to your audience, and respected sources of information often come from the community. It's definitely a team effort. And I see another question that other contemporary public health issues like issues of obesity in the population, addiction, mental illness, the broad, as you recall, cessation is critically important, but the tobacco control movement uses many facets. The complex problems require comprehensive approaches. What's your experience with that movement, that in tobacco control, that it was not simply a focus on helping smokers quit, but it had community-based approaches focusing on the industry? How about that approach that could be applied? What about that approach that could be applied to other public health problems?
I think it's essential to be comprehensive in our approaches and not to limit exclusively on the treatment side. You know, if I look at the epidemiology of tobacco use and what has had the greatest impact on driving down smoking rates, one of the biggest things is just price and price elasticity. When Obama raised the price of cigarettes by $1 a pack, there was a marked decline in prevalence. And while I've primarily focused on cessation, I've recognized that cessation, absence the policies, it won't go anywhere. We need to, do this comprehensively. Most people have seen what are called the tips ads, tips from former smokers, a massive campaign to really personalize it and show what happens to individuals who smoke. Um, that has led tons of people to think about quitting and many of them to quit.
It's a good point. One of the populations that we've talked about often is kids. What's your experience between the balance of children, or I should say adolescents particularly, between quitting or should all of our energy be focused on prevention? Sort of how do you balance that in the adolescent, young adult population?
Yeah, and I mean, there's a third one besides quitting and prevention, and that is policy. And kids are very price sensitive, more price sensitive than adults. Um, Kids are influenced by peers and advertising, and they're really influenced right now by social media. So kids have been uninterested in quitting, but they do stop, and often because of other factors. What is cool or not cool at any particular moment, and how much it costs to buy the product that they want to use.
That's a great point. And it is remarkable if you ever look at the price of the product, how it's changed from the 30 cents or so when we were young. Now, I'm not confessing to ever having purchased cigarettes, but I know some people who did. Let me ask about your comment about the 10 greatest public health achievements, and whether you think that should have an asterisk on it now with the advent of e-cigarettes. Is it still clearly we made progress in the last century, and tobacco prevention and control have been among the greatest accomplishments. But is that going to continue, or is the industry got some other tricks up their sleeves?
No, I'm optimistic. I think that in my lifetime, tobacco use will be essentially eliminated, and it'll be when the government has the political will to reduce the nicotine content to near zero. It won't get to zero people smoking, but it'll get close to that, and that will be an incredible achievement. I don't think e-cigarettes will undermine that. I don't.
What do you see? So we've talked mostly about sort of work here at the UW and in Wisconsin and nationally, but what about globally? What challenges do you see across the world, particularly in developing or underdeveloped nations, that the tobacco industry might be exploring? We have a great global health program. Students are really interested in global health on this campus. Where does tobacco control fit in, and what's your sort of global view of the issue?
Yeah. Well, the tobacco industry sees South America, Asia, Africa is their new marketplace. And they're very effectively marketing their products and getting new populations addicted. Um, and so we have a giant challenge internationally. Um, and for many of these poor countries, cessation treatments just aren't an option. So it has to be via policies that tobacco is discouraged and through government action. The good news is that some really progressive countries like New Zealand and Australia are moving towards banning of the sale of tobacco products, something that was never even discussed in the past, but now is on the table. So I would say, the global issue is a giant one and will eliminate tobacco use in America before we do it worldwide, that's for sure.
Yeah, it's a great point. Uh, as we made progress in reducing per capita consumption, shown by Dr. Tempty's slide, global exports by the industry increased right alongside with the declining in the U.S. market. What about, I want to just ask the question about cannabis. That's a combustible product with harms in and of itself, but we've seen increasing legalization, decriminalization of cannabis across not in this state, but across the country. Have you done work in that area, thinking about the interplay between cigarette smokers and cannabis users?
Yeah. We've done a little work there and we've submitted a couple grants. None of them have been funded yet, but it's an important area of focus of the Center for Tobacco Research and Intervention. Um, Cannabis is, to me, one of the leading threats out there. Again, because it's been illegal, we don't have data on all of its effects. And like e-cigarettes, you're putting stuff into the alveoli that shouldn't be there. And I have enormous concerns about cannabis from the perspective of the harm it may do. Most people don't smoke anywhere near a pack of joints a day, but some people smoke a substantial amount of it, a smaller percent than cigarette smokers, who, for the most part, smoke a good amount of cigarettes per day. Um, so it's a giant issue. I'm not, I've had very serious concerns about the legalization versus decriminalization, which are two different approaches to it.
Yeah, it's a good point. Certainly, I think the consensus is that decriminalization has been good for society, good for public health. But the jury is certainly out on the benefits or the health effects of
Well,
legalization.
and make one other point. There's enormous amounts of dual use, it's referred to, dual use, where people who smoke cannabis also smoke cigarettes, and similarly, who use combustible cigarettes and then use e-cigarettes when they can't use combustibles. So dual use is a big problem out there too.
That's a good point. Let me shift in this last part of our time together tonight to retrace your personal experience. One question that we have is the issue of, you've mentioned a bit about personal attacks and sort of the backlash, not just from the industry, but in general. Have you had any sort of pushback, either from the industry or outside of your work? Any challenges personally for you to continue to pursue this during your career?
I would say remarkably little, in that The tobacco industry, I think, has always felt that their product is stronger than any of our cessation activities. So I think I was probably viewed as he's just focusing on quitting. We've got a better drug than he'll ever come up with. So he's not going to be a problem. So I've not had a lot of direct problems with the tobacco industry. I really can't say that I have, and I'm grateful for that because they have successfully targeted other people that worked in policy areas and ruined their careers and made it difficult for them to work. Luckily, I've never had anything like that.
That's great. What about in Wisconsin? We hear about some of the challenges in rural Wisconsin compared to urban, suburban dwellers. Does your work sort of look at the communities, the differences in communities, and the environment in which people live and work, sort of the rural-urban divide that we see, and how might that be addressed in the future?
Sure. I mean, rural areas in general are poorer, and poorer people smoke at higher rates than more wealthy people. So the rates of smoking in rural areas in Wisconsin and nationwide are higher. That's why we need to make sure that treatments are accessible broadly. So we have what's called the Wisconsin Tobacco Quit Line, where anyone anywhere in the state can call 1-800-QUIT NOW and get access to free treatment, which includes phone-based counseling, web-based resources, and we send them 2 weeks of free nicotine medicine as a starter kit. Smokefree.gov is the National Cancer Institute's suite of web-based resources, including text programs to help people quit. So even if you don't live in a place like Madison or Milwaukee where there might be smoking cessation specialists, we have other ways to help you to quit.
And let me just ask you to maybe repeat that number, but also reflect on your work with the Quit Line, because when we started working on this issue, there wasn't such a thing, maybe with the American Cancer Society, but you developed that here in Wisconsin and it became a model program. Is this a national program? Do you think Wisconsin, in a way, does it better by funding the Quit Line? And so where does that fit into your recommendations for moving forward?
Well, it's a wonderful population-wide approach to helping people to quit. Tim Baker and I just wrote an editorial called 10 million calls and counting. So we've had 10 million people call quit lines across the nation now. It's really remarkable. And I just want to give a shout out to Tommy Thompson because he is responsible for the National Quit Line Network. Back in the early 2000s, he asked me to head a subcommittee on cessation for HHS, the Department of Health and Human Services. And one of our recommendations was to establish a national quit line network. And he squeezed $50 million out of the CDC and the NIH to do that. And we did it successfully. And it's been going ever since 2004, I believe, is when it started.
Wow, that's great. A final few questions. We have an audience of public health and medical students, along with other learners and teachers. If you were to think back on your career or your work, what one pearl, or you can mention a couple, would you want them to take home tonight and put in practice in their health professions careers?
Well, one of the biggest problems with burnout now that we're facing is that clinicians are being asked to do too much in too little time. And then they're asked to document it as well in the electronic health record. I would say if you're a clinician and you have a smoker in front of you, you have to at least mention it. You don't have to do a comprehensive intervention, but at least mention that, have you thought about quitting, and could I give you some access to some options like the quit line and smokefree.gov, a prescription for varenicline or the patch. So to set as a personal standard, you don't let a smoker leave you without addressing it. It's a high standard, but it's one that can really make a difference clinically, and it ends up making a big population difference.
That's a great point. Sometimes, individually dealing with one patient at a time, you don't see the broad impact of those successes because they don't come every time you try to help a smoker quit.
And another point is, when we talk to patients, two things are really come forward. One is that clinicians, particularly doctors, telling them to think about quitting matters. It matters in a powerful way. The second thing is, people are dynamic. They may be totally uninterested in quitting today, and then they hear that their best buddy just got lung cancer, and tomorrow they may be a different person. So don't assume that they're never going to be interested. Bring it up every time.
One of the things we teach in our undergraduate class is models of behavioral health and the trans-theoretical stages of change, the Prochaska's model. Can you talk about that in your both your research and your clinical practice? Sorry, you referred to the stages that people might be in.
Yeah, and we don't use stages of change particularly. I know it's very popular, but we don't, because it just didn't match the science as well around tobacco. But clearly, everyone's not ready to quit today. And one area that we're doing a lot of research at our center on is, how do you motivate people who aren't interested in quitting to think about it? So increasingly, we're saying to people things like, I know you don't want to quit, but how about wearing a patch every day? Continue smoking and see if you feel like your desire to smoke lessens, and it almost always will. And we have the benefit then of increasing self-efficacy and people thinking, well, maybe I could actually do this thing.
That's a great point. It wasn't that long ago when that would have been sort of recommended against, to both use nicotine in people who continued smoking.
Yeah. And yeah, it's entirely safe.
Yeah. What about pregnant women? I know you've done work with helping women who are pregnant both quit but also stay quit after delivery. What about the use of nicotine replacement therapy in pregnancy, and thoughts about the work you've done with Sue Ann Thompson in the First Breath program across the state?
Yeah. As chair of the Public Health Service Clinical Practice Guideline Panel, we did not recommend using nicotine for pregnant women because there wasn't an evidence base to support it, and the potential risks to the fetus were unknown, and thus we chose not to make that recommendation, although obstetric and gynecology societies do recommend it in some instances. Sue Ann Thompson, the wife of former Governor Tommy Thompson, has been an incredible leader for really women's health across our state for 25 years now. We've partnered with her from day one. She's has a program called First Breath that's a national model for helping pregnant women quit.
Yeah, and it continues to be an issue. These are particularly some of the populations that you describe, women who may come from a background of poverty or different backgrounds, certainly rural populations. One area that we'd like to sort of close with is the question of what's in store The question I'm looking at actually says in the next 30 years. So assuming we're all around for another 30 years, or maybe not, what do you predict sort of coming in both research and practice? So maybe thinking about what research ideas are C3 putting forward? What are sort of the future of research in this area? And then maybe I'll finish with the question about what do we need to do individually and collectively. But let's focus on what do you see as cutting edge research in the next couple of decades?
Well, our center continues to focus on the healthcare delivery system as one of the primary venues to capture smokers and intervene with them. So how do we do that better is an area that we're focusing on, and we have a number of studies that are examining that. Other areas of research are how do we deal with smokers who aren't yet ready to quit? How do we deal with dual users, e-cigarettes and um, combustible cigarettes? People with mental health diagnoses smoke at some of the highest rates in our society. We have very little to help them right now, and we need to do more for those populations. So those are some areas that come to mind.
And how about in the practice and sort of either in the clinical realm or in society? What do you see as
Yeah,
coming up?
sure. I would say the point I've made a couple times now, we have the potential to end the tobacco epidemic by reducing the nicotine content of all combustible products to near zero non-addictive levels. That will end the epidemic.
And final question: what we have again, younger individuals on this at this seminar, and thinking about recommendations for young people beginning their career, either in public health or in the medical profession. Looking back on your career, what would you say were some of those decisions that you might recommend others consider?
Well, you got to be passionate about what you're doing. It's hard to, get up and do this every day without being passionate. I would love people to be more passionate about tobacco, but I know everybody's not going to feel in the same way about it than I do. But follow your passion is the thing I think I would say.
Well, that's great advice, Mike. You have been passionate about this from the moment I first met you. I remember that coffee shop in Atlanta where you were either here in Wisconsin or planning to go back, and I was considering it too. I think for me, it was a great move back home, and I can tell by your accent you're not Wisconsin born and raised. There's a little bit of a Boston accent there still. But we are so glad that you came to Wisconsin to train as an EIS officer and then came back after your training with the Office on Smoking and Health and have contributed so much to our knowledge about tobacco prevention and control, but also the practice. It's really incredible. A lot more work to be done. I'm sure if others want to call you, follow up, opportunities for work with C3, I've had many students and colleagues benefit from that work, and certainly appreciate your mentoring me throughout my career. So I'm going to pivot back to Dr. Temte to bring the session to a close. John, you're still on mute, I think. Yep, I see.
I'll figure this out. Well, thank you so much, Pat and Michael. This was wonderful. I continue to be both a clinician and a public health professional, and the contributions to both detrimental health in our patients and detrimental health in our population from combustible tobacco products is immense. And so I'm very grateful to you, Dr. Fiore, for reminding us of that important component. Thank you for the tips you've provided. And more than anything, thank you for the 30 years of service you've provided through the Center for Tobacco Research and Intervention, because this is really such a key element of our medical practices and our public health practice. So speaking from the School of Medicine and Public Health for both of you, we appreciate your time, your thoughts, your conversation. Take care now.
Thank you.
Thanks, Mike.